Okay, HSM 801, page 776. Technical facilitators. A technical facilitator is an NHIS accredited body engaged to provide initial and ongoing technical facilitation or program management where necessary for the establishment and implementation of CBHIPs. All NHIS accredited HMOs are qualified to function as technical facilitators. However, CSOs, FBOs, and limited liability companies can be registered to function as technical facilitators where they meet the requirements for registration. Functions of technical facilitators. A. Generate primary and secondary data for the purpose of program design and monitoring. B. Determine benefit package and contribution rates in consultation with community members. C. Conduct medical auditing and quality assurance. D. Conducts capacity building activities for the BOTs and participating healthcare facilities. E. Supervise and monitor program activities. F. Assist new participating communities to set up BOTs. G. Send regular reports and feedback to NHIS communities and facilities. Community-based social health insurance program in Nigeria. Hygia Community Health Plan HCHP, the first program to be run in Lagos and Kwara states under the oversight of the Health Insurance Fund HIF, an international not-for-profit organization that undertakes to deliver private health insurance and services to low and middle-income families. Anambra State, where a government/community healthcare co-financing scheme is in operation. This scheme mobilizes the community via a health committee which has overseen refurbishment and re-equipping of the publicly owned health center, sourced drugs, and employed or redeployed health personnel. The community members themselves set the premium to enroll at a specified amount per month for each adult and child respectively. The scheme focuses on maternal and child health. Enrollment in the scheme was reported to be 15.5% in a non-successful community but 48.4% in a successful one. High enrollment was linked chiefly to increased awareness of the scheme, while low enrollment was linked to regressive contributions, failure to fit implementation to a specific area, insufficient community involvement, and lack of trust in the scheme and its management. Community-based social health insurance program in Nigeria. 1. Shell Petroleum Development Company pioneered CBHIS in its host communities. The scheme, which was established in 2010, utilized the Obio Cottage Hospital as its healthcare provider. It was primarily set up to serve 4 host communities. 1. Ogbinigba. 2. Rumu Biakani. 3. Rumu Omasi. 4. Rumu Ezuelu. The annual premium payable by each enrollee at the inception was 7,200 naira. SPDC paid 50% of the premium, while the enrollee, that is community member, paid the balance of 50%. The program is, however, open to non-host community members who pay 100% of the annual premium. In 2014, SPDC discovered that most of the host community members did not enroll into the scheme and therefore were not benefiting. The contributions were therefore reviewed. Enrollees subsequently pay an annual premium of 10,000 naira per person. Enrollment is open to all interested individuals. Currently, all enrollees pay 100,000 naira, 100% of the premium. SPDC stopped its subsidy for premium even for host community members, but still provides all other necessary supports for the scheme. The program uses 2 HMOs. Fund utilization. The premium is disbursed as follows: capitation for primary care 50%, secondary care 30%, administrative services 10%, co-payment for surgeries is 35% by enrollees and 65% by HMO. For chronic non-communicable disease, e.g. diabetes, mellitus, hypertension, co-payment is 50%, while the HMO pays the balance of 50%. The staff and volunteers of the facility are paid from the proceeds of the scheme, except those who are posted to the facility by SPDC. A similar scheme was recently established by SPDC at the PHC Rumu Kurushi. Management model. The management model for the SPDC Obio Cottage Hospital runs CBHIS is a board. The management model for the SPDC Obio Cottage Hospital run CBHIS is BOT as program managers. The BOT, that's Board of Trustees. The structure comprises the BOT Board of Trustees and a management committee for the day-to-day administration. So the Board of Trustees, you have the chairman, CMD of the hospital, community rep, River State rep, SPDC retiree, HMO reps. Then you have Shell nominee, secretary. Okay, that's the chairman. Then you have Shell nominee, you have secretary, you have MOH, Obiakpo. Okay, that is for BOT. The chairman is the shell nominee. The CMD of the hospital serves as the care secretary. River State Rep serves as the MOH Obiakpo local government area. For the HMO reps, you have one for each HMO. Management committee, CMD, deputy CMD, matron, operations manager, human resources manager. Drivers of success and sustainability of CBHIS. It has been noted that CBHIS is plagued with myriads of problems, most of which are operational. 1. Contributions has been usually inadequate due to high inflation rates for financing the basic health needs of most low-income families. Again, the size of the schemes is too small to enjoy economies of scale. B. Lack of mechanism in CBHF for assessing the quality of care offered by healthcare providers, which may undermine efficiency. C. Reimbursements in the absence of negotiated fee schedules may also be difficult to determine. D. Sustainability is a very potent challenge faced by the CBHF. E. Poor legal framework by the CBHF may lead to collapse in the event of unforeseen mishaps on key members of board of directors or financial insolvency. F. Inability of the target population to pay for scheme membership. G. Inadequate financial support. H. Unrealistic enrollment requirements, which in most cases is linked to failure on the part of administrators to align real-world socioeconomic conditions with those suggested by theoretical models to account for the target population's willingness to pay for a scheme. I. Non-engagement of communities in decision-making from the earlier stages. J. Failure to engage beneficiary in participation in CBHI. K. Lack of comprehensive cover. L. Patient preference is not given sufficient attention. M. Packages suitable for one community may not suit another. Conclusion. Okay, so it has ended. So we enter the next topic, the Nigerian health system, alternative medical care, by Dr. I.D. Alabere, MNI. Outline, introduction, components of health system, indicators for health system performance, Nigerian health system, theories of disease causation, alternative medical care, health professionals groups and health team. Introduction. Health system. A system is an arrangement of parts and their interconnections that come together for a purpose. WHO described health system as a conglomeration of elements that work together simultaneously in a coordinated manner to bring about all activities whose primary purpose is to promote, restore, or maintain health. Health system therefore comprises of all the organizations, institutions, and resources that are devoted to produce health action. This includes efforts to influence determinants of health as well as more direct health improvement activities. The health system delivers preventive, promotive, curative, and rehabilitative interventions through a combination of public health actions and healthcare facilities that deliver personal health care by both state and non-state actors. The actions of an effective health system should be responsive and financially fair while treating people respectably. A health system needs staff, funds, information, supplies, transport, communications, and overall guidance and direction to function. Like any other system, the health system is a set of interconnected parts that have to function together to be effective. A health system is composed of many parts, prominent among which are 1. Patients. 2. Families. 3. Communities. 4. Ministries of Health. 5. Healthcare providers. 6. Healthcare financing bodies. Components of health system. Traditionally, the health system has 6 components. 1. Service delivery, responsible for delivery of safe and qualitative care with minimum waste of resources in a manner that ensures equity and fairness to all. Good service delivery comprises quality, access, safety, and coverage. 2. Health workforce, to have the right number and mix of trained health professionals. A well-performing workforce consists of human resources management, common skills, and policies. 3. Health information management system, providing accurate and timely information for surveillance, monitoring and evaluation, and decision-making. A well-performing system ensures the production, analysis, dissemination, and use of timely and reliable information. 4. Medical products. Access to essential, safe, and effective medical products and commodities. Procurement and supply programs need to ensure equitable access, assured quality, and cost-effective use. 5. Healthcare financing. A good health financing system raises adequate funds for health, protects people from financial catastrophe, allocates resources, and purchases goods and services in ways that improve quality, equity, and efficiency. 6. Leadership and governance (stewardship). Effective leadership and governance ensures that the existence of strategic policy frameworks, effective oversight and coalition building, provision of appropriate incentives, and attention to system design and accountability. Indicators for health system performance. 1. Health service delivery. 2. Health workforce. 3. Health information. 4. Essential medicines. 5. Healthcare financing. 6. Leadership and governance. So look at them one after the other. Health service delivery. Under that, you have 1. Number and distribution of health facilities per 10,000 of population. 2. Number and distribution of inpatient beds per 10,000 population. 3. Number of outpatient department visits per 10,000 population per year. 4. Proportion of health facilities offering specific services. 5. Number and distribution of health facilities offering specific services per 10,000 population. 2. Number 2 indicator, health workforce. Under that, you have 1. Number of health workers per 10,000 population. 2. Distribution of health workers by occupation/specialization, region, place of work, and sex. 3. Annual number of graduates of health professions/educational institutions per 100,000 population by level and field of education. 3rd indicator, health information. Under that, health information system performance index through review of national health information system. Number 4 indicator, essential medicines. Under that, you have average availability of 14 selected essential medicines in public and private health facilities. 2. Median cost consumer price ratio of 14 selected essential medicines in public and private health facilities. Number 5 indicator, healthcare financing. Under that, you have 1. Total expenditure on health, National Health Accounts, NHA. 2. General government expenditure on health as a proportion of general government expenditure, GGHE/GGE. Number 3. The ratio of household out-of-pocket payments for health to total expenditure on health. Number 6. Leadership and governance. The policy index through review of national health policies in respective domains such as essential medicines and pharmaceutical, TB, malaria, HIV/AIDS, maternal health, child health, immunization. Nigerian healthcare system. That's the next topic. Nigerian health system is organized to provide healthcare at 3 levels by orthodox health professionals who are trained in modern scientific methods. Health services are provided through the various hospitals and clinics owned and run by the federal, state, and local governments, as well as private individuals, companies, and their organizations. Health services are, however, also provided by other forms of practitioners outside the orthodox medical settings. These practitioners, who are collectively grouped as alternative medical care providers, comprise 1. Traditional medicine. 2. Homeopathy. This is a complementary disease treatment system in which a patient is given minute doses of natural substances that in larger doses would produce symptoms of the disease itself. Number 3. Acupuncture. The treatment of disorders by inserting needles into the skin at points where the flow of energy is thought to be blocked meridians. Meridians are lines of acupuncture points, that is pathways in the body along which the body's energy is believed to flow and along which acupuncture points are located. Number 4. Religious organizations, faith healing. Theories of disease causation. 1. Supernatural. 2. Humus, Gwen, gall, mucus. 3. Contagion. 4. Sin. 5. Miasma. 6. Spontaneous generation. 7. Germ. 8. Multifactorial. Alternative medical care in Nigeria. 1. Traditional medicine. 2. Homeopathy. 3. Acupuncture. 4. Religious organizations, faith-based healing. Traditional medicine. Traditional medicine. Definition. A WHO experts committee defined traditional medicine as a sum total of all the knowledge and practices, whether explicable or not, used in the diagnosis, prevention, and elimination of physical, mental, or social imbalance, and relying exclusively on practical experience and observations handed down from generation to generation, whether verbally or in writing. Traditional African medicine. This is a range of traditional medicine discipline involving indigenous herbalism and African spirituality, typically including diviners, midwives, and herbalists. Practitioners of traditional African medicine claim to be able to cure a variety of diverse conditions, including cancers, psychiatric disorders, hypertension, cholera, most STIs, epilepsy, asthma, eczema, fever, anxiety, depression, BPH, UTI, gout, infertility. BPH is benign prostatic hyperplasia, UTI, urinary tract infection, STI, sexually transmitted infections. Types of traditional health care available in Nigeria. 1. Diviners. 2. Herbalist. 3. Diviner herbalist. 4. Traditional birth attendants. 5. Bone setter. 6. Traditional massagers. Then you have another one, verbal surgeons, traditional psychiatrists. We'll also look at them one after the other. Diviners. Divination from Latin divinare, to foresee, to foretell, to predict, to prophesy, related to divinus, divine, or to be inspired by a god, is the attempt to gain insight into a question or situation by way of an occultic standardized process or ritual. Used in various forms throughout history, diviners ascertain their interpretations of how an inquiry should proceed by reading signs, events, or omens, or through alleged contact with a supernatural agency. Divination can be seen as a systematic method with which to organize what appear to be disjointed, random facets of existence, such that they provide insight into a problem at hand. In Nigeria, this group of practitioners undertake investigations to get solutions to real problems. They employ several methods. 1. Read the stars, astrologers. 2. Palm reading. 3. Use cowries. Herbalist. Herbal medicine, also called herbalism, is the study of pharmacognosy and use of medicinal plants. Plants have been the basis for medical treatments through much of human history, and such traditional medicine is still widely practiced today. Modern medicine makes use of many plant-derived compounds as a basis for evidence-based pharmaceutical drugs. This category of practitioners use herbal remedies obtained from leaves, roots, bark of trees that are prepared in different forms. They constitute the largest proportion of traditional medical practitioners. Some of these practitioners have turned their products into syrups/elixirs, tablets, capsules, creams, and balms. Next point, diviner herbalists. This group diagnose as well as render treatment to the sick. Number 4, traditional birth attendants. These people, who are mainly women, assist pregnant women during delivery. Most of them also provide antenatal services. Some of them are knowledgeable in incantations. The Nigerian healthcare system has incorporated some of these practitioners into the primary healthcare organization. Number 5, bone setters. These people specialize in setting broken bones. Some of them use incantations in their practice. In recent times, some bone setters have modernized their practice by requesting for X-ray films of the affected parts to guide them in their treatment. 6. Traditional massagers. This group undertake treatment for a variety of cases ranging from musculoskeletal pains to cases of CVA with paralysis. Next one, barber surgeons. These practitioners believe that any swollen or painful part of the body has bad blood and is responsible for the condition and should be extracted. Barber surgeons, B-E-R-B-E-R, surgeons. They use horns or wide-mouth bottles to extract the bad blood after making some scarifications on the affected part of the body. Barber surgeons also carry out vulvectomy. Next point, traditional psychiatry. This group offer care to mental cases. Most of them employ incantations in their treatments. Problems with traditional medicine. As recent reports have shown, in addition to many benefits, there are also risks associated with different types of traditional medicine / complementary or alternative medicine. Although consumers currently have widespread access to various TN/CAM, CAM treatments and therapies, they often do not have enough information on what to check when using traditional medicine, complementary or alternative medicine, in order to avoid unnecessary harm. While traditional medicine has a lot to contribute to the health and economy, much harm has resulted from unregulated sale and misuse of traditional/alternative medicine and herbs in the country. Extensive patronage of traditional medicine has significantly delayed patients seeking professional health care. Why traditional medicine still persists? Low coverage of orthodox medical services. The coverage is 30 to 40%, with about 75% of medical practitioners providing services in urban areas. Disparities thus exist in the provision of orthodox medical care, hence they resort to alternative care. 2. Apparently low cost of care with flexible payment plans. 3. Belief system of the people. To the believing minds, traditional medicine works. Its obvious failures are usually explained in one way or another. Sometimes the results arrived at through the use of traditional medicine are by chance. 4. Some traditional remedies work, and there are sound scientific and empirical justification for their success. Next point, some of the materials used in herbal practice are of proven pharmacological efficacy, e.g. raffia, which is used in purgative and emetic mixtures with a sedative effect. Due to its sedative effect, the patient becomes very weak and drowsy and can easily be overpowered in traditional psychiatric practice. Next point, the traditional healers do not usually limit their attention to the illness, but also look into the social aspects of the patient, e.g. family affairs, business. Next point, sometimes the healers are not neutrally in the course of care. They intercede spiritually on behalf of the patient. Next point, usually traditional medicine is not as invasive as orthodox medical care. Next point, in traditional psychiatric treatment, the relatives are involved and there is therefore a continuity of home life. Health professional groups. The health workforce is classified according to the following two broad aggregated categories. 1. Physicians include generalist medical practitioners and nurse and specialist medical practitioners. 2. Nursing and midwifery personnel includes nursing professionals, midwifery professionals, nursing associate professionals, and midwifery associate professionals. 3. Dentistry personnel includes dentists, dental technologists, dental therapists, dental technicians, dental assistants, and related occupations. 4. Pharmaceutical personnel includes pharmacists, pharmaceutical technicians, pharmaceutical assistants, and related occupations. 5. Laboratory health workers includes laboratory scientists, laboratory technologists, laboratory technicians, laboratory assistants. 6. Radiography personnel, radiographers/image scientists, radiography technicians, and related occupations. 7. Environment and public health workers include environmental and public health officers, environmental and public health technicians, sanitarians, hygienists, district health officers, public health inspectors, food sanitation and food and safety inspectors, and related occupations. Number 8. Community and traditional health workers includes community health officers, community health extension workers, community health education workers, family health workers, traditional and complementary medicine practitioners, traditional birth attendants, and other related occupations. 9. Other health workers includes a large range of other cadres of health service providers such as medical assistants, dietitians, nutritionists, occupational therapists, medical imaging and therapeutic equipment, engineers and technicians, optometrists, ophthalmic opticians, physiotherapists, personal care workers, speech pathologists, and medical trainees. Number 10. Health management and support workers includes other categories of health system personnel such as the managers of health and personal care services, health economists, health statisticians, health policy lawyers, health information officers and technicians, ambulance drivers, building maintenance staff, and other general management and support staff. Disaggregated. The health workforce is classified according to the following 18 categories. 1. Physicians includes generalist medical practitioners and specialist medical practitioners. 2. Nursing personnel include nursing professionals and nursing associate professionals. 3. Midwifery personnel includes midwifery professionals and midwifery associate professionals. Note that for some countries, nurses with midwifery training are counted under nursing personnel. 4. Dentists includes general and specialist dental practitioners. 5. Dental technicians/assistants includes dental technicians, dental assistants, and related occupations. 6. Pharmacists include pharmacists. 7. Pharmaceutical technicians/assistants include pharmaceutical technicians, pharmaceutical assistants, and related occupations. 8. Laboratory scientists include laboratory scientists, laboratory technologists. 9. Laboratory technicians/assistants include laboratory assistants/laboratory technicians and related occupations. 10. Radiographers include radiographers and related occupations. 11. Environmental and public health workers includes environmental and public health officers, environmental and public health technicians, sanitarians, hygienists, district health officers, public health inspectors, food sanitation and safety inspectors, and related occupations. Community health workers. Number 12 includes community health officers, community health extension workers, community health education workers, family health workers, and related occupations. Number 13. Traditional medicine practitioners include traditional and complementary medicine practitioners and associates. 14. Traditional birth attendants include traditional midwives. 15. Medical assistants include medical assistants, clinical officers, and related occupations. 16. Personal care workers includes institution-based personal care workers, home-based personal care workers, healthcare assistants, and other categories of care assistants in health services. Number 17. Other health workers includes a large range of other cadres of health service providers such as dietitians, nutritionists, occupational therapists, medical imaging and therapeutic equipment technicians, optometrists, ophthalmic opticians, physiotherapists, speech pathologists, and medical trainers. And medical trainees. Number 18, health management and support workers. Includes other categories of health system personnel such as managers of health and personal care services, health economists, health statisticians, health policy lawyers, medical records technicians, health information technicians, ambulance drivers, building maintenance staff, and other general management and support staff. Health team. Health team, this is defined as a group of persons who share a common health goal and objectives determined by community needs and towards the achievement with each other of the team, and towards the achievement of which each member of the team contributes in accordance with his or her competence, and skills, and respecting the functions of the other. The health team comprises the hospital team and the community health team. The hospital team consists of physicians, nurses / midwives, pharmacists and technicians, laboratory scientists and technicians, radiographers and technicians, physiotherapists, clinical psychologists, social workers, and health auxiliaries. The community health team consists of community physicians and nurses, community health officers, community extension workers, traditional birth attendants, traditional medicine practitioners, etc. Conclusion. Okay. So next one, Travel Medicine by Dr. I.D. Alabere, MNI. Outline: Introduction, magnitude of international travel, human mobility and the spread of infectious disease, morbidity and mortality in international travel, infectious disease of potential risk for travelers, health requirements for international travel, preparation for international travel, advice to international travelers. Introduction. Definition: Travel medicine is a branch of medicine that deals with the prevention and management of health problems of international travelers. It is also known as emporiatrics. International travelers are subjected to various forms of stress that may reduce their resistance to diseases. Some of these are: 1. Crowded departure and arrival halls. 2. Long hours of waiting. 3. Disruption of eating pattern, change in climate and time zones. Travel medicine involves pre-travel consultation and evaluation, contingency planning during travel, and post-travel follow-up care. Information is provided by WHO that addresses health issues for travelers for each country, as well as the specific health risks of air travel itself. Reasons for travel. Some people move from one place to another for the following reasons: 1. Pleasure, holidays, visits to places, friends and relatives. 2. Economic benefit. 3. Academic interest. 4. Medical tourism. 5. Political commitment of nations, peacekeeping, peace enforcement for soldiers and policemen. 6. Out of necessity or because their old location is no longer safe. Such human movement is influenced by various factors: A. Environment, climate change, natural disasters. B. Demographic, increase in the worldwide population. C. Socio-economic, under that you have conflicts, globalization of the economy, urbanization, easy access to information. These factors, intertwined in a complex form, have contributed to an increase in the number of travelers worldwide, including migrants. Scope of travel medicine. The field of travel medicine encompasses the following disciplines: 1. Epidemiology. 2. Infectious diseases. 3. Public health. 4. Tropical medicine. 5. High altitude physiology. 6. Travel-related obstetrics. 7. Psychiatry. 8. Occupational medicine. 9. Environmental health. 10. Military and migration medicine. Magnitude of international travel. Almost 1.077 billion international journeys were undertaken in 2012. About 658.4 million of these travelers were from developed countries. About 406.6 million were from middle and low-income countries. About 80 million travelers went from developed to developing countries. Several millions from developing countries to other developing countries and developed countries, including illegal migrants. About 1.134 billion international tourist arrivals, overnight visitors, in 2014. About 1.186 billion international tourist arrivals, overnight visitors in 2015, increased by 4.6% from 2014. The Americas. Growth in international travel by UNWTO region. The Americas, Asia, and the Pacific regions recorded close to 6% growth in international tourist arrivals in 2015. Europe is experiencing 5% growth. Middle East increased by 2%. Africa recorded 3% decline, primarily due to weak tourist arrivals in North Africa. UNWTO report for 2016 showed an increase of 4% over that of 2015, with 956 million arrivals from January to September 2016. The highest increase in international arrivals between January and September 2016 was recorded in Asia and the Pacific region, with 9% increase compared with 2015. Source regions of travelers in 2015: Europe 53%, Asia and the Pacific 24%, America 17%, Middle East 3%, Africa 3%. Travel motivations in 2015: holidays, recreation and leisure related travel 53%, business and professional travel 14%, visiting friends and relatives, religious reasons and medical treatment 27%, unspecified reasons 6%. UNWTO forecast for 2030: leisure, recreation and holidays represent 54%, business and professional travel 15%, health, religion and other purposes 31%. UNWTO forecast for 2030: forecasts of international tourist arrivals predict an average of 3.3% increase until 2030. In absolute numbers, international tourist arrivals are expected to increase by almost 43 million a year on average between 2010 and 2030. At this rate, international tourist arrivals worldwide are expected to reach 1.4 billion by 2020 and 1.8 billion by the year 2030. From a regional perspective, Asia and the Pacific is expected to witness the strongest growth in tourist arrivals, where the forecast suggests an increase by 331 million over 2010 to 2030 period to reach 535 million in 2030, with a growth of 4.9% per year. Tourist arrivals are also expected to double in the Middle East from 61 million to 149 million. Africa from 15 million to 130 million in the period from 2010 to 2030. Predictions suggest growth in Europe from 475 million to 744 million. Americas from 150 million to 248 million will be slower compared with the projections for other regions. UNWTO data for 2019. There was remarkable growth in international arrivals in January to September 2019, though even uneven across regions. International tourist arrivals (overnight visitors) grew 4% in January to September 2019 compared to the same period in 2018, with mixed performance among world regions. The Middle East plus 9% led growth, followed by Asia and the Pacific and Africa both 0.5%, Europe plus 3%, and the Americas plus 2% enjoyed a more moderate increase. The global economic slowdown, trade tensions, and the rising geopolitical challenges, social unrest, prolonged uncertainty about Brexit, and lower business confidence have weighed on growth in international tourism. The 2020 World Tourism Barometer showed that there were around 1 billion fewer international arrivals worldwide in 2020 compared to 2019 as a result of widespread travel restrictions put in place by nearly all countries to try and control the COVID-19 pandemic. The coronavirus pandemic had a devastating effect on international tourism in 2020, causing a 74% drop in international arrivals, according to the United Nations World Tourism Organization (UNWTO) annual report. UNWTO estimated that the fall in arrivals will lead to a loss of 1.3 trillion in revenue, 11 times the losses caused by 2009 economic crisis, which is described as the worst year in history for the sector. The pandemic affected all the world's regions, with Asia and the Pacific region suffering an 85% drop in international tourist arrivals. The decline in the Middle East and Africa was 75%. Europe recorded a 70% fall in international arrivals, despite a slight recovery in the summer, while there was a 69% decrease in the Americas. UNWTO data for 2021 and 2022. Year 2020 was the year in which international tourism came to a near complete standstill, and the only alternatives were domestic and local tourism. Year 2021 saw some improvements, but only in a very subtle way, as restrictions were still in place and many countries kept their borders fully or partially closed. There were 1 billion fewer international tourist arrivals in 2021 compared to 2019. Loss of $1.0 trillion in total export revenues from international tourism in 2021. The situation for tourism remains rather unusual as a result of the COVID-19 pandemic. International tourist arrivals increased 2.1% in January to May 2022 over 2021, but remained 50% below 2019. The crisis marked a significant change for everyone and above all for tourism, one of the sectors hit hardest by the virus. Despite 2.1% increase in international tourist arrival from January to May 2022, it was difficult to make an estimate for 2022 as it is not known how the pandemic will evolve. International travel restrictions still maintained by both destinations and airlines in order to offer 100% security to the consumer. Reinforcement of COVID-19 testing. 2 years after the pandemic, COVID testing was still in place as a preventive measure. Conscious travel was advocated. Travel to more distant destinations but with prolonged durations of stay as consumers look to enjoy as much of each place they visit as possible. UNWTO data 2023. World destinations welcomed 22% more international tourists in the third quarter of 2023 compared to the same period in 2022, reflecting a strong Northern Hemisphere summer season. UNWTO Tourism Barometer November 2023. An estimated 975 million tourists traveled internationally between January and September 2023, an increase of 38% over the same month of 2022, though 13% fewer than in 2019. UNWTO Tourism Barometer November 2023. Overall, tourism recovered 87% of pre-pandemic levels in January to September 2023. That put the sector on course to recover almost 90% by the end of the year. Total export revenues from international tourism, including both receipts and passenger transport, reached $1.7 trillion in 2023, about 96% of pre-pandemic levels in real terms, that is, excluding inflation. Tourism direct GDP recovered pre-pandemic levels in 2023, reaching an estimated $3.3 trillion, equivalent to 3% of global GDP. Asia and the Pacific reached 62% of pre-pandemic levels this period due to slower reopening to international travel. However, performance among sub-regions was mixed, with South Asia recovering 95% pre-pandemic levels, but Northeast Asia only about 50%. UNWTO Tourism Barometer November 2023. Global search results for inbound travel to China significantly improved in Q3 2023 by nearly 40% compared to Q2. In terms of Chinese outbound travel, hotel and air ticket reservations recovered 80% of pre-pandemic levels in Q3. This shows signs of gradual recovery of cross-border traffic further to China's reopening of borders early that year. To ensure international travel, on 24th November, China announced a unilateral 15-day visa-free entry policy for holders of ordinary passports from France, Germany, Italy, the Netherlands, Spain, and Malaysia during the period from 1 December 2023 to 30th November 2024. UNWTO Tourism Barometer November 2023. International tourism was well on track to fully recover to pre-pandemic levels in 2024, despite economic challenges such as high inflation and weaker global output, as well as important geopolitical tensions and conflicts. UNWTO Tourism Barometer November 2023. International tourism. UNWTO data 2024. International tourism reached 97% of pre-pandemic levels in the first quarter of 2024. International arrivals (overnight visitors) reached 97% of 2019 levels in the first quarter of 2024, reflecting an almost complete victory of pre-pandemic numbers. An estimated 285 million tourists traveled internationally in the first 3 months of 2024, about 20% more than in the same period of 2023. These results were boosted by continued strong demand, the opening of Asian markets, as well as by enhanced air connectivity and visa facilitation. The Middle East saw the strongest relative growth, with international arrivals exceeding by 36% pre-pandemic levels in Q1 2024. Europe exceeded pre-pandemic levels for the first time in a quarter, plus 1% from Q1 2019. South Mediterranean Europe exceeded pre-pandemic levels by 1%, while Northern Europe recovered 98% of pre-pandemic levels. Sub-Saharan Africa and North America both recovered 95%, while South America virtually reached 2019 levels. Africa welcomed 5% more arrivals in the first quarter of 2024 than in Q1 2019, while the Americas practically reached pre-pandemic numbers 99%. Arrivals in Asia and the Pacific recovered 82% of pre-pandemic levels in Q1 2021, after recovering 65% in 2023. By sub-regions, North Africa saw the strongest performance with 23% more international arrivals in Q1 2024 than before the pandemic, followed by Central America plus 15%, the Caribbean and Western Europe both plus 7%. Human mobility and the spread of infectious diseases. Increases in the global mobility of humans, animals, plants, and products are driving the introduction of infectious diseases to new locations. In recent years, we have witnessed several infectious diseases spread well beyond their previously understood geographic boundaries, as was demonstrated by the introduction of Zika virus to the Americas. We have also witnessed the emergence and spread of novel pathogens such as the discovery of a previously unknown Middle East respiratory syndrome coronavirus MERS-CoV in Saudi Arabia, spreading to distant countries such as South Korea, and most recently COVID-19 with origin in China. Many factors contribute to the global spread of infectious diseases. 1. Increasing speed and reach of the human mobility. 2. Increasing volumes of trade and tourism. 3. Changing geographic distribution of disease vectors. In particular, human travel and migration, especially via air travel, is now a major driving force pushing infections into previously non-endemic settings. Each year, there are several numbers of international tourists, more international refugees and migrants, greater capacity for shipping by sea, and greater international air travel passenger volumes. Air travel poses a growing threat to global health security, as it is now possible for a traveler harboring an infection in one location on Earth to travel to virtually any other point on the planet in only 1 to 2 days. Infections introduced through travel may be sporadic and may have little potential for further transmissions, such as Lassa fever introduced into European settings. In other situations, infections introduced by air travel may cause self-limited local epidemics such as chikungunya virus in Italy. More recently, there are a growing number of examples of infections introduced to a new region that ultimately became endemic, example such as chikungunya virus in Latin America and the Caribbean. Vector-borne diseases, including arthropod-borne viruses, present unique challenges as disease vectors such as mosquitoes can be carried over land, in boats or on planes, and may travel between any 2 points on the globe within their lifespan. Such vectors have the potential to infect non-travelers in their new location, as it is seen in airport malaria. Even if a vector is not infected, that vector may become endemic to a new region if there are suitable environmental conditions and then potentially enable future epidemics. The most well-known example of this is the now global distribution of Aedes aegypti and Aedes albopictus mosquitoes, the vectors responsible for a number of arbovirus infections, including dengue, chikungunya, yellow fever, and Zika viruses. Vector introduction is further facilitated by ecological factors such as climate change and urbanization that may enable vectors to flourish in new regions. Mobility and mortality in international travel. International travel exposes individuals to various health risks, leading to patterns of mobility and mortality that differ from those in their home countries. Here are some key points. 1. Injury-related deaths. Injuries, including road traffic accidents, drowning, and homicide, account for a significant portion of deaths among travelers, which are often preventable. 2. Infectious diseases. Travelers are at risk of contacting infectious diseases such as malaria, dengue fever, and gastrointestinal infections, especially when visiting regions where these diseases are prevalent. 3. Chronic conditions. Exacerbation of chronic conditions like heart disease and diabetes can occur due to stress of travel, changes in routine, and limited access to medical care. 4. Number 4. Mental health. Travel can also impact mental health, with issues such as anxiety and depression being common among travelers. Improved methods of data collection have provided a clearer picture of travel-associated health risks, helping to identify high-risk groups and inform pre-travel health assessments. Travelers should be aware of these risks and take appropriate precautions such as getting vaccinated, practicing safe behaviors, and seeking pre-travel health advice. Morbidity data. 1/3 of international travelers experience travel-related illnesses. About 50 to 75% of short-term travelers to the tropics and subtropics develop health problems, usually due to infections. About half of travelers from a developed country who stay 1 month or longer in a developing country get sick. Travelers' diarrhea is the most common problem encountered. Mortality data. Cardiovascular diseases 50 to 70%. Accidents and injuries RTA, drowning, air crashes 25%. Infectious diseases 2.8 to 4%. Morbidity and mortality in international travel. Risk of acquiring illness. This depends on 1. The area of the world visited and time of visit. 2. Length of stay. 3. The standard of accommodation, hygiene and sanitation. 4. Behavior of the traveler. 5. Activities and location of the travel within the area visited. 6. Underlying health pattern of the traveler. Infectious diseases of potential risk for travelers. Infectious diseases are the most common cause of morbidity among travelers with diarrhea and upper respiratory tract infections, leading the list. The modes of transmission for different infectious diseases are 1. Food and waterborne diseases. Under this, you have diarrhea, hepatitis A, enteric fever. 2. Vector-borne diseases. Under this, you have malaria, yellow fever, dengue, leishmaniasis, trypanosomiasis, Zika. 3. Zoonosis, diseases transmitted by animals. Under this, you have Lassa fever, plague, rabies, tinnitus. Then 4. Sexually transmitted diseases. Under this, you have syphilis, gonorrhea, HIV, hepatitis B. 5. Blood-borne diseases. Under this, you have hepatitis B and C, HIV. 7. Airborne diseases. Under this, you have CSM, that's cerebrospinal meningitis, influenza, measles, mumps, TB, COVID-19. 7. Diseases transmitted via soil. You have tetanus, and then you have hookworm. Health requirements for international travel. The control or containment of known risks to public health is one of the most powerful ways to improve international health, since these risks constitute the vast majority of day-to-day events with the potential for a public health emergency. Consequently, WHO and its member states have adopted the international health regulators to avoid international health regulations to avoid the spread of infectious diseases with epidemic potentials without undue interference with travels and trade. Diseases in focus are 1. Diseases that have a sufficiently high global or regional prevalence to constitute a significant risk for travelers, e.g. yellow fever. 2. Diseases that are severe and life-threatening even though the risk of exposure may be low for most travelers, e.g. Ebola, Lassa fever. 3. Diseases for which the perceived risk may be much greater than the real risk and which may therefore cause anxiety to travelers, e.g. Ebola, Lassa fever, avian influenza, COVID-19. Number 4. Diseases that involve a public health risk due to transmission of infection to others by the infected traveler, e.g. Ebola, CSM. Previously, travelers to all countries were mandatorily required to have proof of vaccination against yellow fever, plague, and cholera. This has, however, changed as cholera and plague vaccinations are no longer mandatory for entry into most countries. Pilgrims going to Hajj, however, require cholera, yellow fever, and CSM vaccinations. Yellow fever vaccination is needed in some countries where the risk of infection exists for 2 reasons. To prevent the international spread of the disease by protecting countries from the risk of importing or spreading the yellow fever virus. The countries in this category that require proof of vaccination are those where the disease may or may not occur, but where the mosquito vector and potential non-human primate hosts of yellow fever are present. Any importation of the virus into such countries by infected travelers could result in its propagation and establishment, leading to a permanent risk of infection for the indigenous population. Proof of vaccination is often required for travelers arriving from countries with risk of yellow fever transmission and sometimes for travelers in transit through such countries. Number 2, to protect individual travelers who may be exposed to yellow fever infection. The risk of yellow fever transmission depends on the presence of the virus in the country in humans, animals, or mosquitoes. As yellow fever is frequently fatal for those who have not been vaccinated, vaccination is recommended for all travelers visiting areas where there is a risk of yellow fever transmission, that is in countries where yellow fever is endemic. Preparation for international travel. Global travel exposes many people to a range of health risks. Many of these risks, however, can be minimized by precautions taken before, during, and after travel. Physicians knowledgeable in the field of travel medicine can help their patients prepare for trips abroad by providing advice on ways to prevent or mitigate travel-related illnesses. Assessment. Ideally, the initial consultation and acceptance about travel abroad should occur at least 6 weeks before the intended traveler's departure. The essence of this consultation is to take the pre-travel history, including 1. Documentation of all places the traveler plans to visit, including stopovers and side excursions. 2. The time of the year for the trip. The time of the year may affect the risk of acquiring infections because many infectious diseases have cycles associated with the particular seasons or rising ambient temperatures. 3. The purpose of the visit and the duration of stay. The duration of the trip influences the risk of acquiring a given disease. 4. The traveler's allergy history. 5. Vaccination history. 6. Past medical history and current diseases, medications, and allergies influence vaccine indications and contraindications. Number 7. To allow time for booster immunizations where needed and assessment of any adverse reactions. Each piece of information assists in determining the relative risk and benefits of vaccines and medicines for the trip. Advice to international travelers. General precautions can greatly reduce the risk of exposure to infectious agents and should always be taken for visits to any destination where there is a significant risk of exposure, regardless of whether any vaccinations or medications have been administered. For existing health problems, 1. Ensure that all prescribed drugs that will possibly last for the length of the stay are taken along. 2. All physician instructions concerning diet, medications, and physical activities are complied with. Immunizations. Update all required immunization, including those that are considered necessary but not mandatory. Under this, you have routine childhood and adult polio, pentavalent vaccine, MMR. Then you have required vaccines, which are the yellow fever, CSM, cholera. Then you have the recommended vaccines. So these are the influenza, typhoid fever, hepatitis A and B, and then measles. For food and waterborne diseases, 1. Wash your hands often and always before handling and consuming food. 2. Make sure your food has been thoroughly cooked and remains steaming hot. In particular, avoid raw seafood, poultry meat that is still red or where the juices are pink, and minced meat/burgers that are still red, as they may contain harmful bacteria. 3. Avoid foods at buffets, markets, restaurants, and street vendors if they are not kept hot or refrigerated/iced. Number 4. Peel off fruits and vegetables yourself if eating raw. Avoid those with damaged skin because toxic chemicals can be formed in damaged and moldy foods. 5. Do not use tap water to brush your teeth. Don't use tap water to brush your teeth. Okay. 6. If available, bottled water is the safest choice for drinking, but always check the seal to ensure that it has not been tampered with. When the safety of drinking water is doubtful, bring it to a vigorous boil. This will kill all dangerous microbes present. Number 7. Make sure any dishes, cups, or other utensils are totally dry after they are washed. Number 8. Carry antimicrobials and antimotility drugs like quinolone and loperamide, including ORS. Avoid becoming dehydrated by ensuring that you always drink sufficient amounts of fluids. For vector-borne diseases, 1. Use insect repellents on exposed skin and wash off as soon as possible after exposure to insect ceases. 2. Permethrin-coated clothing and bed nets provide additional protection against insects. 3. Commence chemoprophylaxis where necessary before embarking on the journey where perceived risk of infection exists. 4. Carry specific chemotherapeutic agents in case of clinical disease where the possibility of getting appropriate treatment immediately is remote. For accidents and injuries, 1. Careful selection of transportation reduces the risk of trauma and death. 2. Overcrowded vehicles and lack of safety devices make foreign travel riskier. 3. Avoiding night driving and avoiding flying on unscheduled airlines or on airlines with poor safety records may increase safety abroad. 4. Obtain information on the regulations governing traffic and vehicle maintenance and on the state of the roads in the countries to be visited. 5. Before renting a car, check the state of its tires, seat belts, spare wheels, lights, brakes, etc. 6. Know the informal rules of the road. In some countries, for example, it is customary to sound the horn or flash the headlights before overtaking. 7. Ensure that your personal driving license and international driving permit are there with full insurance cover for medical treatment of injuries. 8. Be particularly vigilant in a country where the traffic drives on the opposite side of the road to that used in your country of residence. 9. Do not drive after drinking alcohol. 10. Drive within the speed limit at all times. 11. Always wear a seatbelt where these are available. 12. Do not drive on unfamiliar and unlit roads. 13. Do not use a motorcycle, bicycle, or tricycle rather. 14. Beware of wandering animals. Drowning in recreational waters. Drowning and impact injuries in adults are frequently associated with alcohol consumption, which impairs judgment and the ability to react effectively. Precautions to avoid drowning are: 1. Adopt safe behavior in all recreational waters. Use life jackets where appropriate. Pay attention to and seek information from local residents regarding tides and currents, and avoid outlets in spas and swimming pools. Number 2. Ensure constant adult supervision of children in or near recreational waters, including small volumes of water. Number 3. Avoid consumption of alcohol before any activity in or near water. 4. Check the depth of the water carefully before diving, and avoid diving or jumping into murky water, as submerged swimmers or objects may not be visible. Number 5. Do not jump into or jump onto others in the water. Conclusion. That's the end. Thanks. So we ended at page 848. So the next set of recordings will start on page 849, which is Global Health by Dr. I.D. Alabere.